Good morning, good afternoon, and good evening to you all, and welcome to the kickoff of the SYSTAC Europe seminar series. You're very welcome to be here. My name is Dr. Rachel Cassidy, and I'll be the SYSTAC Europe host for this session. A special thank you to Dr. Kwamie, Dr. Zubin, Shroff, and Dr. Robert Marten for giving your time to present to us today. We'll be discussing the latest WHO Alliance flagship report, Systems for Health, Everyone Has a Role. So we'll start with a quick overview of the upcoming seminar series, followed by an introduction to our guest speakers and the main presentation. We'll then have time for a Q&A on the report before closing the session at around 4 p.m. Central Europe time. Great. So just in case this is your first SYSTAC event, just a quick reminder of who we are. I put some QR codes on the slides. So as I mentioned, the groups, you can find out more information after the session. So at SYSTAC Europe, we are one of 5 regional hubs that sit under the SYSTAC global umbrella, SYSTAC meaning Systems Thinking Accelerator. Dr. Kwamie is going to talk further on SYSTAC as a global network in a moment, but just to highlight that we're working together to provide a platform and to promote systems thinking methodologies within health systems and policy research. A needs assessment has been conducted by each of these regional hubs to better understand what the gaps are for researchers and practitioners working in systems thinking in these regions. The focal areas identified are listed on the screen for SYSTAC Europe. So namely, to support mainstreaming of systems thinking beyond research, how we can really translate research into practice is very important. Supporting dialogue with European policymakers and trying to bridge that gap. Also really important is cultivating new systems thinkers. And I give a special mention here to my colleagues who expertly lead the SYSTAC Europe Forum, which among other activities are currently organizing in collaboration with the SYSTAC Americas Hub, a peer support program for aspiring systems thinkers within the field of global health. If that's something that speaks to you, we've got the QR code there, so please sign up and you'll receive emails about these activities. We're also interested in promoting applied systems thinking experiences and practices with activities such as mapping practical systems thinking experiences for health, which is an ongoing activity at the moment, and the seminar series that we're kicking off today. Just talking a little bit to the focus and the activities planned for this seminar series. We all know that health system dynamics and performance are directly affected by the behavior and activities of adjacent systems, including dynamics associated with societal, political, food, and economic systems. Systems thinking approaches are ideally placed to further our understanding on the linkages and feedback that exists between these different systems. In this SYSTAC Europe seminar series, we're going to have colleagues, researchers and practitioners presenting on various topics, describing work on using systems thinking methodologies to analyze problems situated outside the health system, but with direct influence on health system related outcomes. We're going to start with today's presentation from our WHO Alliance colleagues, which I'll describe in more detail in a moment. In September, we're going to be joined by colleagues from Swiss TPH and the Karolinska Institute in Sweden, and the National Institute of Transport in Tanzania. And our colleagues there will be discussing using systems thinking for road traffic and transport systems in Iran and Tanzania. In October, we're going to have presentations from our colleagues at Swiss TPH, the University of Tirana in Albania, the Counselling Line for Women and Girls and Women to Women organizations in Albania, and the Yamana Institute in Basel, Switzerland, on applying an intersectional systems thinking lens to strengthen the response to violence against women in Albania. And finally, we're going to end this series in January with colleagues from Uppsala University in Sweden, where we're going to be discussing the newly developed SHIFT framework, which has been developed to assist those working in nutrition and health to implement equitable interventions related to the food environment. So if any of these are speaking to you, please sign up and you'll receive information about each of these seminars, how to join and when they're taking place. So I'm going to end this introductory presentation with a little background on our guest presenters and the focus of today's main presentation. The WHO Alliance for Health Policy and Systems Research, otherwise known as the Alliance, was an early advocate for systems thinking in health policy and systems research. You'll likely have seen the flagship report that was published in 2009 by the Alliance, which was fundamental in introducing systems thinking concepts within the field of health system strengthening. Since that time, the Alliance has continued to support knowledge generation and capacities for systems thinking within this field, such as the SYSTAC network. The Alliance is widely recognized for its flagship reports that address questions that confront policymakers, researchers, implementers, and other practitioners. They are a key instrument in promoting ideas that address current gaps or challenges, and in stimulating thinking and debate on priority topics identified by stakeholders in the field. Today's presentation focuses on the Alliance's latest flagship report, Systems for Health, Everyone Has a Role, that was released at the HSR Symposium in Bogota last November. We're pleased to have with us today 3 Alliance colleagues, Kwamie, who leads the Alliance's work on systems thinking, and 2 of the latest flagship report's editors, Zubin, Shroff, and Marten, to provide an overview of the report that's going to be followed by a Q&A session. So please, really, we encourage your participation and we want your questions. So just a little bit of background on our speakers. Zubin is a health system specialist with over 10 years of experience in the areas of health governance and financing, human resources for health, and access to medicines. At the Alliance, he leads portfolios of work on health policy analysis, health financing, and health emergencies. He holds a doctoral and master's degree in global health from the Harvard School of Public Health and a medical degree from the University of Delhi. He believes that the Alliance's position straddling research and policy-making communities enables him to leverage his analytical skills towards stronger health systems, something that he has been passionate about since first entering medical school. So thank you so much, Zubin, for your time today. Great. Robert focuses on health systems and primary care, healthcare. He is also working on health policy and systems research and how this can be applied to help manage and control NCDs and the climate crisis. Robert holds a doctoral degree from the London School of Hygiene and Tropical Medicine. And before joining the Alliance, he worked in the WHO India country office and was previously the health systems coordinator for the WHO in Sierra Leone. Welcome, Robert. Great. And last but not least, Aku is a health systems researcher. Her work has focused on applying complexity theory to health systems governance, management, and leadership. She's particularly interested in district-level health systems, as well as learning and mentorship in health policy and systems research. She leads the Alliance's portfolios on systems thinking and capacity strengthening. Welcome, Aku. Great. So I am going to leave it there and hand over to Dr. Kwamie for the start of the main presentation. So Aku, when you're ready, the floor is yours.
Great. Thank you very much, Rachel. Thank you to you and to all of the colleagues at SYSTAC Europe for this invitation and this opportunity to present some of this work today. So I'm going to go ahead and share my screen. I believe you can all see that. And I want to start just by giving a few very brief comments on how the Alliance has contributed to systems thinking in health policy and systems research, just picking up on some of what Rachel has already mentioned. So as many of you, I think, know, the 2009 Alliance flagship report was on systems thinking for health system strengthening. And as Rachel said, this was really the first time that systems thinking concepts had been introduced to health systems strengthening and within health policy and systems research more broadly. And this report has actually been one of the most cited Alliance resources in its lifetime. It still remains relevant. It's had more than 1,200 citations. And really, we can see that this was really a seminal moment in terms of how we think about systems and how we use systems thinking concepts in global health and in public health. And since that time, the Alliance has continued to invest in systems thinking. In both 2012 and 2014, the Alliance supported special journal supplements around systems thinking. The first was really on frameworks and strategies in 2012. In 2014, it was really looking at empirical examples of applications of systems thinking in low and middle income countries. And yet we've seen that over the past 15 years, there hasn't been the same uptake of systems thinking in policy and practice as there has been in research. And so in 2019, the Alliance began to really reinvigorate this portfolio. And we were working in 3 countries, in Botswana, Timor-Leste, and Pakistan, with colleagues at SYSTAC around getting district health managers to use systems thinking in their routine practice. And that work, as it was being done virtually during COVID times, really began to bubble up the ideas of how can we build communities of practice. This was from the experience that the colleagues were having around virtual support and bridging across countries. And we thought, how can that be expanded to be more global in scope? In 2021, we also had a limited 5-episode podcast on systems thinking, and you can still download that from the Alliance website. But also in 2021, this is when we began to incubate this global community of practice that we call the Systems Thinking Accelerator. So Rachel has already mentioned a little bit of this global network that's made up of 5 regional hubs. 1 hub in Costa Rica, 1 hub in Ghana, 1 in India, and 1 in Manila, in addition to the hub in Europe that's co-led by the University of Geneva and SYSTAC. But the idea was really threefold. Number 1, to create a platform for systems thinking science and practice, bringing people together, both researchers and practitioners who were struggling with how to apply systems thinking in their own work, how to define the field, but also how to exchange experiences. Number 2 was really around developing this community that was engaging with these tools and methods and really supporting a critical mass of both researchers and implementers, policymakers, and practitioners to use systems thinking in their work. And then finally, to be an amplifier, to continue to share and document these lessons, but also continue to advocate for greater use of systems thinking. And just a final word to say that some of the results from the needs assessment really have pointed to the perception that even though we speak about systems thinking, there is still a greater need for its application, a greater need for understanding which tools are ideal for which kinds of problems, a greater need to document the experiences of systems thinking that is already taking place, and then, of course, to build, share, exchange, and learn. And so that brings us now then to the most recent flagship report that the Alliance has produced last year. And we're going to now hear from my colleagues, Zubin, Shroff, and Robert Marten, to take us through this presentation. So Zubin, I now hand the floor over to you.
So thank you, Aku, for that introduction. And thank you, Rachel and SYSTAC Europe, for the invitation and the opportunity to present this latest flagship report. My colleague Robert and I will be presenting a brief overview of the report, which will then be followed by a session and opportunity for questions and audience participation. So could I have the next slide, please? So just to introduce the Alliance flagship reports, Aku and Rachel have both already mentioned them before. So each 2 years, typically, the Alliance for HPSR develops its flagship report. And this is very much with an aim to address questions that confront policymakers, researchers, implementers, and practitioners. And they serve as a key instrument to promote ideas to address current gaps in the knowledge and challenge our current thinking and debate priority issues. So the most recent flagship report prior to this one was one on learning health systems, where we identified how systems can learn as they evolve and develop. We had previous flagship reports of participatory leadership, looking into access to medicines through a health systems perspective, and of course, the systems thinking flagship report that Aku mentioned in her presentation, and that this community would be intimately acquainted with. Could I have the next slide, please? So I begin with an overview of why this report. This is what chapter 1 really focuses on. Why this report at this time, Systems for Health. So COVID-19 demonstrated to us, we are thinking of this in early 2020, the centrality of 3 things. Firstly, the inability of health systems to provide essential services in parallel to addressing the emergency. And we saw this was striking in nearly every country, irrespective of country income group. Countries that should have had capacities to manage the pandemic and continue providing services were struggling to do so. We saw problems in Europe and North America, as much, in fact, more than in many LMICs. A second thing we noticed was the negative consequences of the cycles of panic and neglect, as it's been called, when it came to emergency preparedness and response. So we see that there have been previous emergencies. People talked about never again, post-Ebola, for instance, but then a few years later, everything was forgotten till the next emergency came along. And the third and quite an important thing which actually underlies this report, and we'll see the framing of it, is the importance of non-communicable diseases as a significant determinant of COVID-19 morbidity and mortality. And I think this really forced us to think of the link between health emergencies and health promotion, whereas efforts to health promotion efforts focused on NCDs are seen as being separate from health emergencies, but underlying health was seen as this very important determinant of COVID morbidity and mortality. Could I have the next slide, please? So there was something clearly problematic with our underlying conceptualization of health systems, and they were clearly inadequate to address improvements in health in a world where 70% of deaths are caused by NCDs, and where, on account of climate change, deforestation, increased animal to human interactions, we can only expect health emergencies to get more common over time. So we made the case that health systems as they are conceptualized are inadequate, and they're inadequate for two principal reasons. Firstly, and this is largely you see with the framing of universal health coverage, they focus on access to healthcare services and financial protection. These are the two indicators in the UHC coverage index. Countries are often measured on account of how close they are to this in terms of providing services and reducing out-of-pocket expenditures. So there was much less attention paid to health security and health promotion efforts within this framing of health systems. The second was that health systems, as they were conceptualized up to date, have largely predated the information revolution. Information revolution that has transformed not only how governments and people communicate and engage with each other, but also how people prefer to access health services. We see a whole proliferation of digital technologies that have changed the way in which people monitor their own health, how health can be delivered to remote communities, things such as telemedicine. And our frameworks were simply not up to the task, so to speak. They were not fit for purpose, given that they predated these very significant revolutions in technology that had taken place. Could I have the next slide, please? So we thus need to move beyond systems that are focused on treating illness and delivering services, which is the core of what health systems have been doing so to date, to systems that address the challenges of health security and health promotion while continuing to provide essential services. And the key word here is and. And in the wake of the pandemic, there was an understandable concern of all resources then going to health security, resulting in distortions and displacement and crowding of other priorities, as we had seen, of course, earlier with HIV/AIDS. And which is why we made the argument of holistically looking at both of these. And by looking holistically at both of these, and Robert will allude to this more in his discussion of the final chapter, we made the case that investments in health security and health promotion are synergistic. For instance, efforts to improve population health through nutrition reduces susceptibility to tuberculosis, which reduces the need for more advanced antimicrobial use, widespread use, which in turn reduces the threat of antimicrobial resistance. On the other hand, a lack of health security, as we saw in the COVID pandemic, complicates efforts to make populations healthier. You have massive limitations on people's mobility. So therefore, we wanted to make this link between these two different elements and present the fact that your investments in one are not mutually exclusive of investments in the other. And we define systems for health as systems ready to respond to both known and unknown future threats, hazards, and risks. And they address the social, economic, environmental, and commercial determinants of health that are critical to securing and enabling healthier societies. In sum, a much broader conceptualization of than health systems have been to date. Could I have the next slide, please? So now I go on to discussing chapter 2, which really examines health systems frameworks and their limitations and their evolution over time. So we begin this chapter by discussing how frameworks are models. They are simplifications of reality that highlight the essential features and organizing ideas. They are not in health systems in and of themselves. They can be descriptive, they can be explanatory, they can be both. Importantly, we know that they shape and determine programming, prioritization, and investments. And we have the history of the building blocks, for instance, have been actually used to organize how ministries of health are organized in many low and middle income countries. We have a department dealing with HRH, we have one dealing with access to medicines, we have one department dealing with service delivery, one with health financing. this is really an example of how a framework is actually been used to determine programming and prioritization. Frameworks, as we researchers know, are important to create a common understanding and shared language, and they're very important to inform the design and conduct of research. So there are many appropriate uses of frameworks, but frameworks are often used inappropriately, and they can become ends in and of themselves. And the power of framing of an issue can become a limitation. So we saw this, of course, very importantly in most frameworks of health systems, where their emphasis on healthcare as opposed to broader structural and social determinants of health have meant that these actually got crowded out from our conceptualization of health systems, with health systems being exclusively seen in terms of the delivery of services. Could I have the next slide, please? And in this chapter, we describe the evolution of frameworks over time, from those which looked exclusively at health systems inputs, actors, supplies, and functions, to those that recognized the importance of issues such as power, trust, governance, and influence, what have been called the software elements, to complement the hardware elements of the health system. However, this still is inadequate, and we saw in reviewing the frameworks that most of the frameworks are insufficient to inform practical action to address the challenges of health security and healthy populations. For instance, the control knobs framework and the building blocks frameworks both overlook the essential public health functions that lie at the core of emergency preparedness and response. We also have very little to say about the commercial determinants of health. And this is, it's only obvious because they're really looking at healthcare services and the delivery of services, not looking at how these broader structural and factors influence the performance of health systems. Could I have the next slide, please? So we conclude this chapter 2 with identifying 4 elements that we believe need much greater emphasis as we develop the area of systems for health. The first is building trust and addressing power. And by trust, we mean trust between patients and providers, among governments, private sector, and CSOs, and amongst communities themselves. We need to address power asymmetries, and power plays a very important role in determining who gets what, when, and how. And this is power asymmetries between donors and government agencies, which of course determine the availability of resources in donor-dependent countries. Power between multinational corporations and public health interests, which are particularly important now as we look at the importance of NCDs in the disease burden as we go look to the future. Power asymmetries between governments and citizens in allowing citizens to exercise their health entitlements. So a greater emphasis to addressing power and building trust. A second factor that we see is increasingly important is engaging communities and focusing on rights. And communities are extremely important in co-producing their own health, and this is only increasingly recognized now. A focus on rights, on the other hand, is important to direct resources to the most marginalized and vulnerable within communities. It's often not enough to just talk about engaging communities. We are interrogating the sort of disparities that exist within communities and actually addressing some of the power asymmetries that exist within these communities themselves. Could I have the next slide, please? We also identify the importance of working across sectors. Interventions needed to enhance health security and make populations healthier really need action across sectors. We see, for instance, in NCDs, the importance of regulation of commercial firms that are traditionally outside the domain of the health sector, be it sugar-sweetened beverages or tobacco, which is, of course, which is immediately outside the health sector. We need to address the climate crisis, which needs us to go beyond the health sector, looking at other sectors. In terms of health security, looking at One Health requires us to engage with agriculture, animal health, and the environment. So really looking ahead, we do need to find ways of strengthening multi-sectoral action and actually bringing this about. And the fourth is the need to go beyond national boundaries. And we know that the challenges of health security and healthy populations need action beyond these individual boundaries. Similar to working across sectors, I said, commercial determinants of health, one needs to have global mechanisms to deal with cross-border tax evasion by large multinational corporations. Climate change is something which needs collective action across countries. And similarly, antimicrobial resistance too needs action across both sectors and across countries. So this is a broad overview of the first 2 chapters of the report. I hand over now to my colleague, Robert, to go through chapters 3 to 5.
Excellent. Thank you so much, Zubin. Thanks, Aku, and thanks, Rachel, for the invitation and opportunity to be here. Thank you all online for joining. Good morning, good afternoon, good evening. I'm happy to be able to present and share with you some of the thinking from the report. If we could have the next slide, please. As Zubin said, I'm going to cover the remaining chapters. So that's chapter 3, chapter 4. But I'll spend most of my time on chapter 5, which is the recommendations. And then, of course, we're very much looking forward to your feedback, questions, and discussion in the time that we have remaining. So for chapter 3, here we really focused on how systems for health can create healthy populations. And we go through all 4 of the elements that Zubin mentioned in the last few slides. I'm going to highlight 2 of the 4 elements here. So, for example, we highlight examples in the report about how engaging communities to co-create, to co-produce health can transform health outcomes, with examples from the National Health Assembly's asbestos ban in Thailand, and the role of the TAC, the Treatment Action Committee campaign in South Africa in ensuring access to ARVs. We also highlight the importance of going beyond national boundaries, with an example, a short case study on the international effort to remove lead from petrol in every country around the world that concluded, I think, in a couple of years ago in 2021. If I could have the next slide, please. In chapter 4, here we focus on how systems for health can ensure health security. And again, here we go through all the 4 elements. I'll highlight another 2 here. So, for example, in one case here, we focus on the importance of building trust. And we go through a case study in Dharavi slum in Mumbai during the COVID-19 pandemic. We also highlight the role of a multi-sectoral committee in Trinidad and Tobago in addressing the COVID-19 pandemic. Next slide, please. So for chapter 5 here, we really try to bring it together and show how, having a systems for health approach can not only ensure health security, create healthy populations, but also achieve universal health coverage. And as Zubin mentioned earlier, we think there's a lot of potential synergies of alignment, right? That we know that healthy populations are intrinsically also more secure. We saw this again through the COVID-19 experience that really influenced our thinking. But there are other examples, right? We know, for example, that reducing the use of tobacco, improving nutrition, can improve or reduce tuberculosis, reduce the need for antimicrobials, reduce AMR, right? We also know that when you improve environments, built environments, that can contribute to controlling dengue or malaria or cholera, right? The same with measures to control epidemics. There's significant physical mental health consequences. Again, I think we have to look no further than the recent COVID pandemic to be reminded of this. Again, the idea here is identifying that we really shouldn't be just focusing on one of these, right? We shouldn't be just trying to control a pandemic, or we shouldn't be just trying to create healthier populations. There's a way that we can bring this together. And that is really the purpose of the focus on systems for health. Next slide, please. So here we talk about the potential benefits of alignment. So again, bringing this together in a systems for health approach. At the global level, we think that there's opportunities to reduce resource competition, right? So it's not about an agenda that is simply looking to ensure health security or control pandemics. It is about trying to create healthier populations, trying to ensure universal health coverage, trying to advance all of our health goals, right? And of course, there's reduced potential for fragmentation, duplication, overlap. we think this is also, there's kind of opportunities here for increased buy-in from both low and middle income countries and high income countries as well, because we're addressing common interests of countries at the global level. And as Zubin mentioned, we were very much influenced by not only the Ebola experience about 5 years ago, but also learning from some of the global health initiatives, from the maximizing positive synergies effort in the late 2000s. And we think there are opportunities to do things differently this time. And that's both at the global and the national level, right? At the national level, of course, there's benefits here in terms of reducing parallel programs, reducing kind of parallel processes. There's potentials also to provide ministries of health a single entry point to engage with other sectors to facilitate advanced multi-sectoral action. Next slide, please. So we had recommendations here for actions at the local and national levels, as well as at the global level. And I'm going to just highlight a few of them here in the next few slides. So next slide, please. So at the local and national level, we thought there were opportunities to align policy processes, integrate planning, budgeting, monitoring, and we give specific examples in the report. We also thought there were opportunities to prioritize implementer and community perspectives in the policy design and implementation, really kind of going from the bottom up. But of course, at the same time, investing and promoting kind of effective leadership at the national and local levels to be able to move this forward. Next slide, please. We also, of course, as related to this, emphasize the need to empower a health workforce with broad competencies to connect across sectors, right? So, sometimes you see in some health systems that there's community health workers or community health volunteers that are, they might be funded by a certain agency or a certain department, and therefore they prioritize certain interventions or issues. We think there's an opportunity to do better, and that starts by empowering the health workforce to be able to go beyond specific mandates. We also think there's opportunities to leverage digital transformations. We also think there are opportunities to build trust and improve availability and the use of flexible funding. Next slide, please. At the global level, obviously, again, and I think this report is an effort to begin to do that, to emphasize the commonalities, to try to create a new language, create new understandings, reframe our efforts to bring together sometimes disparate efforts. We think as part of this that there could be opportunities to broaden our set of indicators. And we also think that there's opportunities to kind of support the use and generation of knowledge to advance the systems for health approach. Next slide, please. Thank you. A big thank you for your attention. We're looking forward to your questions and feedback. Over.
Wonderful. Thank you so much, Aku, Zubin, and Robert, for that brilliant presentation. We already have some questions coming in. So I don't know if the three of you can see the Q&A. I'll also read out the question as well. So our first question is from John Answer. How can the WHO Alliance help connect systems thinking, systems modeling practitioners in academia to countries and organizations with systems thinking needs? Maybe Aku?
Well, let me start, and then I'll invite Zubin and Robert to add. And good to see, John, that you're on the line. I hope that you're well and that the conference went well. I mean, this is part of the remit of the Systems Thinking Accelerator, to be able to actually bridge and bring these communities together. One of the things that the Alliance is working on as well is a new white paper, where we actually have been engaging some system science specialists to actually come together with health policy and systems researchers, for us to be able to think through what is needed in health policy and systems research for the next 10 years when it comes to the application of systems thinking. In as much as we continue to hold up the 2009 flagship report, one of the things that the past 15 years has made quite clear is the fact that there is still room for us to be a bit more theoretical when it comes to drawing on system science theory, not to be academic, but to actually inform our praxis, inform that. And so that we know that there are methods and methodologies currently within the streams of system science that we as health policy and systems researchers can do better in deploying. Having said that, one of the other efforts of SYSTAC is actually to bring to fore who is working in which areas. And we have colleagues such as your colleague, David Machar, who we know are doing really interesting things with authorities, for example, the Singapore Health Authority, actually bringing in and using systems dynamic modeling to actually inform the reforms in real time there. So SYSTAC is still quite young and expanding. And I think one of the things that we're putting an emphasis on in the mapping is also learning who is doing what and how we can bring them together, but then how we also document better. And then how we also use more systems thinking theory and practice in our methods. I hope, John, that that's answered your question, and I invite Zubin and Robert if there's anything for them to add as well.
Just to add to your point, Aku, I think that another way in which we're seeking to bring in systems modeling practice into countries and organization systems thinking needs is by actually conducting research which is demand-driven. And I think that when we see demand-driven research where policymakers come up with questions and then we bridge that with systems thinking practice, bring systems thinking practitioner and modelers to actually address those questions, it can help them create a virtuous cycle of increased demand for systems thinking and create a sort of culture within ministries of health where systems thinking approaches are actually embedded into their thinking rather than it being something completely separate, which of course aligns with the aims of SYSTAC.
Wonderful. Robert, did you want to come in? No. Okay, great. Thank you, Aku and Zubin. Just to say, if you would prefer not to type your question, you can raise your hand and then I can pass the mic over to you. Our next question is from Sally Shiab. Thank you for the session. I wanted to ask about the point going beyond national boundaries, which Zubin mentioned in his presentation. I wonder about the specifications regarding this point in conflict settings, where the issue of resources and governability is highly affected in such contexts. What can be done to include such settings in the framework without maximizing the gap, while applying the framework between other countries with higher level of governability of their resources and countries with lower to absent level of resources governability? I think maybe Zubin, we would start with you.
Thank you very much, Sally, for this question. I think there are two things I'd like to emphasize here. I think one is that this is not a framework in the sense of it's a one-size-fits-all approach where we're trying to say, do this and you will have systems for health. We're here trying to understand the elements that are important to simultaneously address health promotion, health emergencies, while continuing to maintain access to essential services. With that in mind, we don't see what the emphasis on bringing a focus of looking beyond national boundaries and working across sectors is that in our efforts to support health systems, irrespective of income levels, whether these be post-conflict settings, conflict-ridden settings, middle-income countries, upper-middle-income countries, if we don't look at these issues holistically, we're bound to fail. And that's why what for a conflict setting, what I would say is this is to raise the attention to development partners and donors that don't look on this wholly as a band-aid that you're a fix in a humanitarian crisis, but you equally need to invest in governance capacities to mitigate or prevent, even if can't prevent, mitigate the next crisis. And I think that's the emphasis here that we're trying to bring in of why we raise these four elements repeatedly in a wide range of settings and situations. It's not that, and it's to basically bring to the attention of all those investing in health systems, that health systems are beyond health workers bringing the money in, having the pharmaceuticals there. If you don't look at these, you're not getting a good return on your investment. And I think that's the next frontier we'd seek to develop, of actually demonstrating the sort of returns on investment of health systems if you don't look at these elements, and how you'd have a much poorer return if you didn't than if you did.
Wonderful. Thanks, Zubin. Aku, Robert, did you want to come in? No. Okay, great. Our next question is from Harvey Joy Lewanik. Are we seeing more integration of systems thinking and formal training, for example, in the curricula of many graduate or postgraduate programs in public health and global health? Does anybody want to come in for that one?
I'm happy to start and then invite Robert and Zubin. Hi, Harvey, good to see you. I think the question is not necessarily about more integration. I think it's actually a question of updating the kinds of systems thinking curricula we currently have. Just to mention two examples that actually are coming out of SYSTAC, our colleagues at the University of the Philippines in Manila last year actually did develop short course module on implementation research, but also using systems thinking. And I know that this year they're running their second iteration of that course. So that's one example where, and Zubin made the point about demand drivenness, one example where curricula is being developed, but really grounded in the local sort of policy context, which is very important. Our colleagues in Delhi have actually also been developing a regional casebook, trying to collate regional examples of where systems thinking has been applied, but again, being highly localized and contextualized. When we speak to our colleagues at Johns Hopkins, who have been for years running systems thinking as part of their top programs, they actually inform us that they are at the point where they are looking to update what they are teaching. And when you look at some of the associations and colleagues who are US-based on the call can also speak to this, but the Association of Public Health Schools, actually, when you look at the systems thinking competencies that they list that actually make up then the curricula that should be taught, there is a discussion in the US about updating some of those competencies. So I do think that this speaks to the point where we've reached in the Alliance of really trying to say what is needed in global health and public health, health policy and systems research, to look at the next 10 years and see what kinds of skills, competencies, and also organizational capabilities we need to actually develop, be teaching, and also be using research to strengthen systems thinking training. I don't know what other colleagues think.
Nothing to add from my end.
Nothing here to add other than to say I think this next question from Ross about developing scenario simulators for policy experimentation. I think that gets into what Aku was saying in terms of looking at kind of foresight type exercises to say, okay, very much we're focused on 2030 and delivering the SDGs, but why don't we look ahead to 2050 or 2060 and see what do we need? What are the kind of future challenges, and can we begin to get ahead of some of those? And I think this type of thinking and work allows us to begin to do that. Over.
Wonderful. Aku, Zubin, did you have anything further to add for that question?
No, just to say that I think we need to recognize that sort of using a wide variety of tools and being able to come up with estimates of this and scenarios, while being very cognizant of the complexity of systems, is probably important for us as health systems people to make our case to the large global health funders. And I think we shouldn't shy away from that, while recognizing that these estimates may have wide confidence intervals and there are lots of caveats with them. From a very instrumental point of view, I think it's important for health systems specialists to increasingly get into this space that we've often shied away from, for reasons that we are generally very nuanced and careful about making causal claims that many of our colleagues in global health may not be. And they may, in fact, get large amounts of funding for not being so.
Wonderful, thank you. Do we have any hands raised or any further questions? Oh, great, yes. Let me unmute you, John. Yes, please go ahead.
Hi, so really nice to hear such a wonderful presentation. My question, I want to focus mainly on how do you, the WHO Alliance, help to develop capacities across these countries? Because if I look at the map that Aku was showing, you could see that there are a lot of needs across different countries and continents. And the question is, you need to think about how do you develop capacity to help those countries or organizations with such needs. And the issue here is that people can learn something, but then when it comes to practice, learning and practice are two different things. And the question is, how do you create that opportunity for individuals in those countries to develop capacity and practice what they are learning so that they will be able to address specific issues? And I heard somebody talking about demand-driven issues. We have to understand what are the issues that the system or the country or the organization is facing in terms of their health securities, and how those capacities that we develop will be able to respond to those issues. So my question here is, how do you help or create a system that will help train individuals in those countries so that they will be able to address some of these issues that keeps coming up?
Great question. Does anybody want to start?
I'll start, and then I know Zubin has something to say about this. So John, the Alliance sort of broadly, not just limited to systems thinking, but we have a diversity of approaches when it comes to strengthening capacities. We do individual capacity training, and that will be topic specific, usually in the form of fellowships or mentorships. But we also work very much at the institutional level, and will continue to have an institutional capacity strengthening focus. I'll let Zubin to speak to some of our embedded research approaches. But one example that I can share with you actually does come from our work on using systems thinking for district health managers. And essentially that project was set up as a capacity initiative where we wanted to be able to provide some kind of training for district health managers using systems thinking tools. So tools like process mapping, like social network analysis, like basic stakeholder analyses or fishbone analyses. But then iterating that over cycles over time, building in reflective practice, and then actually learning by doing, but having a company support through the technical support centers. And what was very interesting was that work was happening, of course, when COVID happened. And so many of the district teams that we were working with also got swept into the national responses and the district level responses for COVID. And one example was the colleagues in one of the districts we were working in Pakistan, because they had their capacity strengthened and had the time to reflect on what happens when they use this approach versus not using that approach. They chose to actually use process mapping as part of their COVID tracing. And so this was not something that was built into the project, but was clear evidence of the utility of such approaches and the time it takes to sort of learn. So building in that learning approach, building in embeddedness, and also making sure that we're quite intentional about looking at that interface between the individual and the institutional is sort of one Alliance approach, but we do have many, and I'll let my colleagues speak to some of the others.
Zubin or Robert, did you want to come in?
Robert? Okay. So yeah, thank you, Aku. Just to add to, Aku spoke about the embedded approach largely from the side of building capacities and particularly around methods and using systems thinking approaches. I'd like to emphasize that I think we could also look at this from the sort of way of altering policy ecosystems in terms of demand. And for this, it requires strengthening, sensitizing policymakers to the added value of systems thinking and broader health systems research, and also developing institutional mechanisms within ministries of health to actually provide developing platforms which can serve sort of ready, recognized references where MOHs can turn when they have policy questions to support them in developing policy needs. We've had experience in developing these platforms during the pandemic, actually in a couple of countries. As part of the ERA initiative, we have worked in Georgia, India, Malaysia, and Zimbabwe. And we've got some of that information in more available on the Alliance website for those who are interested in how we've actually done this. So I think it's equally important to do that while building capacity of researchers, just to ensure that there is a steady demand for the products that research teams can produce in response to policymaker needs. Over.
Wonderful. Robert, did you want to come in? No. Okay, great. Great. So we are nearing the end. So perhaps the last few questions from Yavora Kazakova. Can you explore perspectives from social psychology applications using these methods?
Zubin? Go ahead. You look keen. I mean,
Aku, this is your area in terms of systems thinking. So go ahead.
Sure. Well, I mean, it's a really, thank you, Yavora, for the question. It's a really interesting one. And it sort of picks up the point that I was making earlier in terms of some of the limitations that we have had in using systems thinking tools and approaches in health policy and systems research. Some of the tools that I mentioned in my response to John were very much come from the spectrum of being able to diagnose a system. And so there are other tools as well, causal loop diagramming, systems dynamic modeling. And those tools will really allow you to diagnose the system in order to be able to intervene. But there's a whole other stream of systems thinking tools and approaches that are much more about making sense of the system, and they are much more participatory in focus and very much about trying to understand the actors within a system and how they perceive the system. What are the system boundaries? Who are the system beneficiaries? What are the system resources, etc. And so those are the kinds of approaches that we've not really used a lot in global health and public health when it comes to systems thinking tools and methods, and that we certainly can benefit from. And so I do see that social psychology would be woven into some of those more participatory perspectives, because of course the actor who is within the system is experiencing the system. The system gets filtered through how he experiences that, and that seems to me to begin to approach the social psychology element in addition to many others. So, and I think that within health policy and systems research, we speak about being multidisciplinary. There are some disciplines that have been more represented than others, but the field is still expanding. And I think that certainly some of these other disciplines, we will continue to see more and more of them, especially as we deal with issues from a health systems perspective, for example, mental health crises, climate change influence, so on and so forth. So I hope that answers your question a little bit.
Wonderful, thank you. We're coming to the end, but I want to squeeze in one more question just before we wrap up. So we have a question from Mark Yamba. I'm apologies if I've pronounced that incorrectly, Mark. The question is, how are funders applying or aligning themselves to systems thinking, including the WHO and many others, as most of them have disease-specific programs and funding? Mark is a PhD student at the University of Zurich.
So let me, Mark, try to answer your question. I think, there is a move to bringing in more applications of systems thinking across funders, including global entities such as WHO and such as the Alliance. One of the places where we have actually seen perhaps more explicit uses of systems thinking when it comes from a philanthropic perspective are more sort of social charities that are sort of locally based as opposed to being internationally based. And I think you can imagine the reasons for that. But clearly, if we are going to be able to support systems thinking methods, we have to actually be a bit more long-term in our perspective and in how we fund. And there is, when you look at the funding landscape, there's a small handful of some funders who are experimenting with longer-term funding horizons and with something that's called adaptive funding, and you can look up that literature and find that there. But I think broadly within the funding landscape, there is a recognition that if we will be more systemic in our approaches and more adaptive in our approaches, then the funding horizons and timeframes have to be a little bit longer to be able to actually capture the systems change that we're looking for. So it's in discourse and in discussion, but of course there's always more to do.
Wonderful. Zubin and Robert, do you want to come in? No. Okay, great. I think in the interest of time, let's leave the Q&A there. I'm sorry I couldn't get through the remaining questions, but thank you so much for your participation. I will just close the session with a final slide. Great. So I just wanted to say thank you so much to our guest speakers today, Dr. Aku Kwamie, Dr. Zubin Shroff, and Dr. Robert Marten for your time. That was a very timely presentation and really very clear. It's very hard to give a presentation and a report in 20 minutes, but that was like very clear understanding of the report. Thank you. And thank you to the audience for your participation today and in the Q&A in kicking off this seminar series. I wanted to a special mention to my colleague Irina, who is here, who's our excellent comms officer at the University of Geneva, who is supporting SYSTAC Europe with organization of these seminars. So thank you so much, Irina. Looking ahead to the next session, which will be hosted by my SYSTAC Europe co-lead and colleague Anna Duchenko, we're going to be joined by Dr. Mariam Tavakoli from Swiss TPH and Daudi Katapola from Karolinska Institute and the Institute of Transport in Tanzania, who will be discussing using systems thinking for road traffic and transport systems in Iran and Tanzania. Finally, yes, just thank you all for your participation and joining today. We've recorded this session, which is going to be available on the SYSTAC Europe website. I think you'll receive a link after the session. So we're looking forward to seeing you all at the next seminar. Until then, take care and we'll see you soon. And of course, thank you so much to our guest speakers for your time. We know you're very busy, so thank you. Thank you for that.
Thank you so much, Rachel. Thank you.
Thank you, colleagues. Bye-bye.